Sorry,
Might have,
now you can hear me. I apologize. It's always something that I forget to do. Um, well, thank you for inviting me for this kind invitation to talk about women and heart disease. I know that predominantly most of the people on this conference are probably diabetes doctors. So but I think now we're more than ever, as I was hearing the last talk, we're all overlapping diabetes and cardiologists. That's the future for all of us to be working together. So I have no disclosures, and I'm going to start just historically that we understood men and women were different, because even if you go back to the ancient Greeks, when they assigned a god of health, they also assigned a goddess of health, understanding that women were somehow different than men, and that was Hygiena. And for the symbol of medicine, which is the staff with the snake wrapped around it, well, Hygiena brought the snake. So that's our symbol in medicine. And I think at those early days, we recognize there's differences. But for heart disease, we're kind of behind the ball. So I'm going to try to point out some of these differences just so that you can understand what they are. This is the US data, and we have good graphical data to look at our trends over time in terms of mortality. Red is depicting women, blue is depicting men, and that's pretty common for all my slides going forward. But as you can see, after in the mid 1980s, we started seeing rapid declines in mortality from cardiovascular disease in the United States in men, and not the same declines in women. If anything, it was increasing, and it became that more women were dying of heart disease. Now, since 2001, we started seeing this reduction in mortality, which was great to see. And finally, in about 2012, we actually, or 14 or 13, I guess, we actually had less deaths of women than of men. But as you can see in the US, now suddenly we're seeing this dangerous trend. Cardiovascular disease is increasing in men and women in the United States. So again, this is probably because of our younger population having more heart disease, more risk factors, being less healthy. But we're seeing similar things for India as well. In India, I'm sure it's no surprise to any of you that cardiovascular disease is now the number one killer. And if you look per 100,000, of course, it's affecting men more than women, but it's still pretty significant in women because it is their number one killer. So, and it's really grown in India. And the rates are actually more than 2 times those than we're seeing in the US. So there's something changing in India, making us all concerned about what is going on. Now, part of the problem about cardiovascular disease in women is that we didn't know much about women. Most of our trials, really, until this last decade or maybe the last 2 decades, really exclusively included men. And Dr. Nanette Wanger, who's one of my mentors in the United States, she said this nicely. She said the medical community has viewed women's health with really a bikini approach, essentially looking at the breasts and the reproductive system and ignoring the rest of a woman when we talk about women's health. Now, she said this statement in about the late 80s. And I wrote an editorial really recently saying, well, when are we going to plan on moving past the bikini and really protect a woman's heart? Because what we are not doing globally is doing good at preventing heart disease. Now, again, I apologize for this being US data, but this is what I have most available. For the United States, so the 1.3 million deaths in the United States, like I said, the number one killer is women, and that accounts for 420,000 deaths in the United States. The second leading cause is chronic lung disease, accounting for just about 85,000 deaths. Lung cancer is the next leading cause, and breast cancer accounts for about about 41,000 deaths in the United States. This is a tenfold greater risk, except women really identify with the risk of breast cancer and underappreciate and are less likely to understand that they're at risk for heart disease. And we know from our most recent data that in the United States, less women actually appreciate their risk of cardiovascular disease than they used to. So there's something that we're not doing right. If we just talk about prevalence, really in the United States, almost 1 in 2 women have some form of cardiovascular disease. That makes about 60.8 million women, compared to breast cancer, where it's 3.8 million women. So just, it's not to minimize breast cancer, but only for us to appreciate this great cardiovascular risk. Now, the data for India is shown here. And what's interesting is, before we were seeing a lot more cardiovascular disease in the rural areas and not as much in the urban areas, but now we are seeing it in both. Stroke rates seem to be reducing, but cardiovascular disease in general is growing in India. And again, these are the death per 100,000 people for male and female. And as I already told you, it's lower in women than in men in India. But for ischemic heart disease, if you just look at those numbers, the number in the bracket are comparing to the normal averages, the normal in the globally. And you can see India is really superseding those in terms of ischemic heart disease. Particularly. And we see this even by people who are Indian immigrants who are living in the United States, and even the first and second generation of children that are now becoming young adults in India, or in North America, I meant, and where we're seeing them having higher rates of heart disease, as well as having them at younger ages. I take care of a lot of my fellows and young physicians from Indian backgrounds who already have cardiovascular disease. So, we have this cartoon, and I like it because it's true, but it's all, we have studies of fruit flies, mice, hamsters, frogs, monkeys, and men with this condition, but medical research using women as subjects just never occurred to anyone. And one might also replace women with South Asians, because we do not have enough research about South Asians, although we are getting some. But related to women specifically, you can see we've taken all studies done, all trials, and you can see that compared to men, women are under-enrolled based on disease type, except for pulmonary hypertension. There's underrepresentation of women in every other type of disease within cardiology. Whether it's drugs, devices, lifestyles, procedures, we under-enroll women. It doesn't matter where the study's done either. Globally, less women are enrolled, and it doesn't matter where the study is done, we under-enroll women. It doesn't matter on the size. For age, we may be good at enrolling people under the age of 55 in terms of women, but not at the higher ages. And we know cardiovascular disease affects people more when they're older. So it's a shame that we don't get enough women at the older ages. And it really doesn't matter on sponsor type. We all under-enroll women. And in fact, if it's government funded, it seems that we under-enroll women even worse. So these are things we need to pay attention to when we interpret our research. And why does it matter? Well, we certainly know women are not small men, right? I mean, why we care about sex is because we care about biology. We care about XX versus XY. And we really need to know the biological difference between a man and a woman. We also need to know gender influences, because being a woman sometimes makes our access to healthcare different, our income different. There's a lot of other variables that are important about cardiovascular disease. But again, my point is, it's the biological influences, meaning what is it? Every cell in our body tells whether it's a male or female. So how our cells and how our organs respond to conditions really does matter as much as all the other risk factors. So, sorry, I'm having trouble moving. my own slides. Let me just get rid of that up there. So one of the questions I would pose to you is whether we even follow guidelines equally in women compared with men. And that can be the first place to save lives. And this is from the data called Get With the Guidelines, which is in the United States. Some of the best hospitals give their data publicly. And looking at myocardial infarction, all myocardial infarction, when we look at these adjusted odd ratios, if women get something more than men, the number will be more than 1. If they're less likely to get it than men, it's less than 1. And if it's equal to 1, it means men and women get it equally. But you don't see a whole lot of 1s or greater than 1s, right? After a heart attack, women are less likely to get aspirin or beta blocker within 24 hours. They're less likely to undergo any type of invasive procedure. They're less likely to meet our standards, our door to balloon time, our door to needle time. They're less likely to get any fibrinolytic therapy at all, actually. And women are more likely to die than men. So that's the only thing they do better is die, particularly when it's an ST elevation myocardial infarction. And that is from some older data, but we continue to follow these trends of data over time. And when it was last published in 2016, we showed still these gaps are existent. It's worse to be a woman, but it's worse to be a Black woman. Women have more bleeding, but we are still not doing as well. And you can replicate this data all over the world and see the same thing. We see gaps in getting women to the cath lab compared to men. This is in people under the age of 55. This is the Virgo study. Under the age of 55 with ST elevation myocardial infarction, there was about an 8-minute gap if you had PCI capabilities in your hospital, but if it required transfer to a closest hospital, it was actually 30 minutes longer, that door to balloon time, opening up that artery for women, which exceeded our threshold for what we recommend when you get transferred. So these are young women under the age of 55. So they have the most to lose. We also know women are more likely to be rehospitalized than men, and especially the younger women. Younger are the solid lines, and the dashed lines are those over the age of 55, and black is men and gray is women. And you can see after a myocardial infarction that even before 1 month, these lines start separating, but following them out past a year, women are more likely to be rehospitalized, which we all care about, right? Because our healthcare expenses, we really don't want people to have to come back to the hospital for recurrent events. The other thing is whether women even experience cardiovascular disease like men. Are we not recognizing them because there's some difference? But the more recent data is actually showing that women and men present very similarly. Again, that study of that younger men and younger women, the Virgo study of those under the age of 55, showed that 90% of young men and young women presented with the classic symptoms: chest pain, chest pressure, chest tightness, or chest discomfort. The difference between men and women was that women were more likely to have 3 or more additional non-chest pain symptoms when you compared that to men. And we see this repeatedly. I'll show you just very quickly that data. But for those under the age of 55, it was more a problem with doctors actually telling them that maybe they needed to go to the emergency room because maybe this is a heart attack. So when women and men, and this is again the Virgo study, the under the age of 55, women were more likely to think it was anxiety and stress. Men were more likely to think it was maybe muscular pain. And when they were asked what made them seek out medical care, men were more worried about heart problems than women, but women were more worried about other health problems. That's what drove them to get to the hospital. But there was greater delays for women than there was for men in terms of being more than 6 hours before women actually got to the hospital. Now, when they sought out medical care before their heart attack for those same symptoms, some of them did go and seek out medical care, and actually more women sought out medical care than men. But women were more likely to be told by a healthcare provider that these were not heart-related problems, in contrast with men. So we as a medical community underappreciate the risk for heart disease in women compared with men. And we have more new data showing that women are more likely to present with these typical symptoms. This is the Hermes trial that was presented in 2019 at ESC, still not published. But again, women and men really presented around the same, almost close to 90%, who had the typical classical symptoms of chest pain. And this is where they used artificial intelligence to listen into the conversation using cardiolinguistics. So it was basically letting a computer capture, did somebody say chest pain? And yes, women said chest pain as often as men. So at the same meeting at ESC, similarly, from the high stake group, they also showed that women who went on to have a myocardial infarction were actually more likely to have the classic symptoms of typical symptoms: chest pain, arm pain, jaw pain, dull, heavy tightness, pressure, ache, squeezing, crushing, or gripping was really commonly seen in those who went on to have a myocardial infarction. So we should get away from this misnomer that women somehow present atypically when they have a heart attack. We really need women to recognize these symptoms and get to the emergency room. Now, there is other differences, and I don't have a ton of time today because I didn't know I only had 20 minutes, so I'll be really, really quick. But even differences in heart failure, women and men have an equal lifetime risk of developing heart failure. The risk increases in age for both men and women, but there's differences in the type of heart failure women get compared to men. Women are more likely to get something called heart failure with preserved ejection fraction, and men are more likely to get heart failure with reduced ejection fraction. And so there is biological differences even in heart failure. There's differences in terms of sudden cardiac death or cardiac arrest, in terms of how we respond to them. Even when they're witnessed cardiac arrest, we're more likely to initiate CPR on men compared to women. And that's a real big problem, right? Because if we don't initiate CPR early, we're less likely to save lives. And yet when we ask, we know that women are less likely to receive cardiac CPR compared with men. And that's why we lose lives when women have sudden cardiac death outside of the hospital. Part of it is we don't teach CPR on anatomically correct dummies. The Annie doll doesn't look anything like a woman. And when we ask why you won't do CPR on a woman, it's often because the community doesn't want to expose a woman or touch her breast, and they don't know how to do CPR on a woman. So we need to replace our mannequins with womikins, because this is also contributing to increased deaths in women. Well, the other question I would ask is whether our guidelines even apply to women. We have these guidelines that have not been really updated in the US. They've been mildly updated in 2014 about stable ischemic heart disease. And not that you have to read all the details in this figure, but basically the whole focus is who needs coronary revascularization. This overt focus on coronary revascularization makes the assumption that when you have ischemic heart disease and you have symptoms, that you have an obstructive lesion. And I don't know about you all, but when I was in medical school, I learned this classic diagram saying the only way you could have an abnormal stress test is when you had this obstruction. This is outdated, this is wrong, and we know that you can have ischemia without an obstructive lesion, but all our guidelines to date really focus on that. And then when our new chest pain guidelines come out in a couple of months, you'll see we've changed that very much. So the European guidelines have definitely changed that focus. We were some of the early people that showed, this is one of my papers where we showed that in women who had non-obstructive coronary disease, so group 2 and 3 of the WISE study, compared to an asymptomatic cohort of women, which are the first group, the symptomatic women were more likely to go on and have cardiovascular events, even when we stratified by risk factors. So there's something about having signs and symptoms of ischemia that really are important, even when they don't have an obstructive lesion. And other people have now replicated that. But this obstructive lesion that we know very well, and as cardiologists, we know what to do with. The problem is these, whether they're non-obstructive or whether it's in the microvascular system, we can't see when we do a cardiac cath. So this idea of a INOCA and MINOCA, which stands for ischemia with no obstructive coronary arteries. MINOCA is when you have a myocardial infarction with no obstructive coronary arteries, may be very female predominant. And that's what we're seeing, and that's what we're all working on now. But my point is that biology matters. Our sex chromosomes dictate how we respond to lifestyle, what hormones we release in our body, how our regulatory molecules affect our organs. So for every disease, it's important to understand sex differences, but for the most important organ, for certain, we need to know. So I'm a preventive cardiologist. I'm just going to briefly spend the last few minutes on some sex-specific risk factors. We use the ASCVD risk score, but a lot of the risk factors don't appear aside from the traditional ones. But even with the traditional ones, and I know you guys are all the diabetes experts, but you know that a diabetic woman is much more likely to develop cardiovascular disease compared with men. In addition, there's some sex-specific conditions that affect that. Gestational diabetes, polycystic ovarian syndrome. Hypertension is more prevalent in women in our older ages, and its risk to women is actually greater than it is in men. And there are some sex-specific issues. So we need to understand, even smoking, although less women smoke, the cardiac risk is greater. So there's diseases like lupus and rheumatoid arthritis that are far more female predominant conditions. And again, although there's not a known difference in terms of the relative risk, given that these conditions occur more often in women, we have to be aware of them. But they really, in terms of our traditional risk score, we use the ASCVD risk score. And now we have added, as of 2018, risk enhancers to take into account the things that don't go into our traditional risk equation. The things that we should be asking specific to women are about pregnancy. Pregnancy can only occur in biological women. And it's nature's free stress test. It identifies women that would benefit from primary prevention efforts to reduce their risk for atherosclerotic cardiovascular disease. Those are preterm delivery, gestational diabetes, gestational hypertension, or any hypertension during pregnancy, including preeclampsia and eclampsia, and fetal growth restrictions. And these four are really the ones that we know well. Macrosomia and parity have a lot more to do with, macrosomia has a lot more obviously to do with gestational diabetes. And parity can be related to socioeconomic status. So we really think the first four are the most important, but 80% of women at least bear one child in their lifetime. And it may surprise you to know that a third of them have one of these adverse pregnancy outcomes. So we need to be asking about that when we're trying to assess cardiovascular risk. We have strong data about the effect of hypertension during pregnancy and its association with cardiovascular disease. And I just like this Northern Finland cohort, but many studies have shown this, but they stratified by any type of hypertension and compared it to normal, which is the black line, saw a greater risk of cardiovascular disease, also chronic kidney disease, hypertension, and diabetes. So knowing that can tell us who's going to develop some of these other conditions. The Caliber study from the UK also showed very similarly, any type of hypertensive disorder during pregnancy or preeclampsia predicted future cardiovascular disease, and lots of different type of cardiovascular disease. It wasn't limited to ischemic heart disease. Gestational diabetes, I don't need to tell any of you that, but this is an elegant study out of France where they followed all deliveries from 2007 to 2008. And those with gestational diabetes, just in 7 years, had a greater risk of stroke, MI, and angina. Think about that, 7 years after delivering a baby. These are still young women. That's my point. You're not waiting for them to be the late myocardial infarction. We're seeing them within the next decade of delivery. These are the young myocardial infarctions. This is some of our work looking at preterm delivery, and we showed that, again, that preterm delivery before 37 weeks predicted a future risk of heart disease, but also stroke, doing a meta-analysis with a bunch of different studies. So we also, important in India, low birth weight. and this is a common problem in South Asians, and it is a common problem in South Asians that live in North America. They do have smaller babies, but yet we are seeing that is a potential risk factor for cardiovascular disease in the future. There may be underlying reasons for that, including genetics, but right now we're not able to tease that out if it's genetics versus other, if who's at a less risk of developing cardiovascular disease. But it's important for our population to know that. The mechanisms aren't entirely clear about pregnancy and what is occurring. They may already have risk factors prior to pregnancy, or there may be something turned on, the inflammatory response of pregnancy, that something gets activated, and that we are seeing these different things going on. But what we do know is that they have a higher risk of cardiovascular disease, and we should be asking about these things as much as the other risk factors. So across the lifespan, just here as a summary slide, I'll show you what I ask my young women, because I only take care of women. But we ask about, age of menarche, polycystic ovarian syndrome, birth control pill, especially if they smoke. We talk about the reproductive years and all those adverse pregnancy outcomes, as well as whether they got fertility therapy or any type of early amenorrhea or premature menopause. Very important to ask, because that also, I don't have enough time to talk about all of that, but that puts an increased risk. And then for older women, menopause and hormone replacement therapy is important to ask. So that's how I approach women. I assess their ASCVD risk, talk about family history, identify high-risk women, one of them being South Asian women, identify sex-specific risk factors, as I just discussed, and then those sex-predominant conditions, lupus and rheumatoid arthritis, again, diseases of inflammation, so ask about them. That's how we personalize it for the patient. We don't need fancy genetics if we aren't just doing the basic biology of men versus women. So I'd encourage you, when you're trying to assess cardiovascular risk, to ask them those questions. So I hope I've convinced you that women have worse outcomes after acute myocardial infarction. But if the only thing we did is give all women guideline indicated therapies, we would save lives. And we know worldwide this is an issue. Younger women are specifically the group we should be most concerned about after acute myocardial infarction. They have the worst outcomes. They are less likely to get the guideline indicated therapies. And I think we underappreciate their risk compared to a 40-year-old man. A 40-year-old woman doesn't get the same type of care. As I hope I've also convinced you, and I think you all know, South Asian women are at high risk. And I also hope I've convinced you that symptoms for angina are often quite typical, but we just need to listen to our women. We need to do more in prevention, and the sex-specific risk factors really need to be considered. And I hope I've also convinced you that we need to include women in our trials, because there's sex differences if we look for them. So this is, my husband put this out on Halloween. I guess this was supposed to be him. He said there's just, he put a sign next to the skeleton saying, "I'm still waiting for her to be ready." But I used it to say there's just so much more to understanding women. So again, thank you for letting me be here today and talking to you about my favorite topic.
Thank you for that wonderful talk. Very, very informative. Outstanding talk, I must say. One of the best I have listened to in last couple of years. And I mean every word of what I am saying. Now, I have a request for you. Would you like to comment on endometriosis in females around 40 or younger? So I could, while trying to acquaint myself with your topic, I went through few of the papers, and I found a reference to a 2016 Brigham Women's Investigator Group, who had this observation that women under 40 years of age with endometriosis had almost 3 times the chance of developing coronary events or requiring revascularization procedures. So what are your comments?
Yeah, so it's a little complicated. I saw that paper too, and I guess we've all been kind of, it's hard to know if it's the endometriosis or something else that is increasing risk.
But I didn't find endometriosis in any of your slides. That's why
no, and this is, yeah, no. Yeah, yeah.
I'm asking you.
Yeah, no, it's a good point because I'm not sure I'm convinced. So the reason is that when you have endometriosis, you also have many other uh, potential things that ultimately happen to you. Obviously, when you have endometriosis, you have difficulty getting pregnant, and so they also get the fertility therapy that can increase their risk. And I didn't get enough time to talk about what we know about fertility therapy, but specifically failed fertility therapy seems to increase the risk for cardiovascular disease. So we don't know if it's the endometriosis, because endometriosis in and of itself doesn't always mean increased cardiovascular risk. But if they have something like polycystic ovarian syndrome, if they have already other risk factors like that are making them at higher risk for heart disease. So it was a little hard to tease that out. And that's been the only study so far, unlike all the other female conditions. So we've actually been waiting for somebody else with more data. And that was an important study, but I think we're all waiting to see it. Does it appear in other populations? Or
Replicated.
other populations to say for sure, is that a risk factor?
And
Just a comment, sir, in this regard. Since endometriosis, I am Dr. Astos. So, hello, hi everybody. The thing is, since endometriosis is one condition which is very difficult to treat, and the pain and agony which a woman is passing through while having this disease, one can only if you treat few patients of endometriosis, you can realize that that is very much. And since these women are having quite a stressful condition, stress is a very important co-factor in this situation. So I guess that can be one of the possible explanation behind the increased cardiovascular risk.
Well, and they, as you said, they, because of their pain and their, they're always often going to the doctor, and other things get dismissed or discounted. So, whether they get full screening or whether they get other things, everyone's focused on, their pain and their issues. But also sometimes we tend to, as a medical community, we tend to be more dismissive to other things that are going on. Everyone kind of like, oh, it's that patient again, rather than, because it's difficult. It's a difficult disease to treat. So I think there's a lot going on, but I think we're not disagreeing that it might be a risk factor, but waiting again for like a little bit more data so that we know what to do. That's a lot with all the pregnancy or some of the younger things, the things that happen in younger women, is that we need a little bit more of the pathophysiology. That's really been kind of the thing that we also don't, I didn't admit this. So you identify those young women, and right now we're trying to determine, what do we do for them? So I get a lot of the preeclampsia patients. They send them to my cardiology clinic, and we're doing prevention in all of them, checking their lipids, checking their blood pressure, helping them lose weight, helping them to do heart healthy behaviors. Do I know that's going to change their outcomes? No. We need some trials to know, what should we do? What is there markers that are going to tell us, biomarkers that will tell us who's at greater risk and who's not? And those are the things we right now are still lacking, but at least we're getting information specific to women, which I guess compared to even 10 years ago, we didn't have this information.
so, as you exclusively deal with women, my next and perhaps the last question is that what is your take on the incidence of HFpEF, the preserved ejection fraction incidence in women, vis-a-vis the quantum of VAT, the visceral adipose tissue? We
Oh,
had yesterday a brilliant talk on this subject by one of our colleagues.
you were saying the incidence of HFpEF, at least, and I know you have a second part to it, but the incidence of HFpEF for women compared to men is basically a 2-to-1 ratio. We definitely see it much more frequently in women. And interesting about HFpEF that I think is really interesting is there's an intersection between microvascular disease that I talked to just briefly and HFpEF. We think it's a continuum. So they might go on and have, ischemia, and we identify them with ischemia, or they can also on that same trajectory go in another direction and develop heart failure with preserved ejection fraction. And we think that potentially if we figure out the treatment for either, it might be the same treatment. But you said that in the relation to, I missed the end.
Visceral adipose tissue.
Okay, yeah, and so again, that there is, in terms of obesity links and adipose tissue, there is that link between heart failure with preserved ejection fraction, and specifically in women. I'm not a heart failure doctor, just so that you know. When I find HFpEF, I send them then to my team that just focuses on that. But it's a really interesting area because we're finding the overlap so strong between so when we have an ANOCA clinic and our HFpEF clinic, actually, to be honest, a lot of those patients probably are having the same pathophysiology underlying it all.
One small comment, ma'am. In India, we are not using ASCVD risk that much as compared to Curis score. The Curis score, the ethnicity and other factors are represented much, and women related factors are also taken care of. In that particular calculator, they have mentioned migraine as one of the risk factors. So migraine being one disease which is more common in women as compared to men. So how do you think this is going to be placed as one of the factors to prevent cardiovascular disease in women?
Yeah, migraine is interesting because migraines are particularly strongly associated with the development of coronary microvascular disease, and that sort of vasoactive responsive that we see of the microvascular system, again, probably is interconnected with our entire vascular system, and why we're seeing it as a link. We don't, right now, in terms of our risk enhancers that we added to the ASCVD risk score, migraine they did not include, but those of us who take care of ANOCA patients and MANOCA patients, we definitely know there's a link. Most of them will recall that they either had a strong history of migraines or still currently have a history of migraines. So it's interesting that that's part of that score that you use. I actually am not as familiar with it because in the US, we use the ASCVD risk score, but the ASCVD risk score is very limited, I think. And I especially as America and Canada become more and more multicultural, we're not representing our entire population because, like I told you, other defaults to white in the ASCVD risk score. And we know for sure that that is not true, just like South Asians are not like East Asians. There's a very big difference in terms of our risk. The Masala study hopefully will eventually be added to that. I mean, we're getting more information. So the Masala study is being done in the United States, and it's of South Asians in the United States. And there's other studies going on as well that hopefully population data will help us, because there is definitely something biologically different about South Asians. Like I told you, I take care of a lot of these patients as well, and they have heart disease and heart disease early, and these are young, thin. Of course, adiposity we think is one part of it, but Lp(a) is another thing that we're seeing very high, even when lipids look completely normal. The only thing we find sometimes is Lp(a) is elevated. And these, I'm telling you, these are my 30-year-old, late 20s, early 30-year-old residents and fellows that are having cardiovascular disease at young ages. So it's the medical community, they're finding us as well, so we need to do more and use specific for the populations. Absolutely.
And among the emerging risk factors, the list contains autoimmune disease, breast cancer treatment, and depression. So do you subscribe to these three?
Yes, and I'm sorry, I cut out those slides when this morning I woke up and saw that my talk was only to be 20 minutes, so I apologize. But yes, breast cancer cancer is a very important condition, and there's a couple of different things that go on with breast cancer. First of all, we know there's an intersection of the same risk factors for breast cancer that are risk factors for heart disease. Additionally, on top of that, there is the treatment, right? So we give, if you get chemotherapy, if you get radiation therapy, they both increase the risk of cardiovascular disease. So what we are trying to encourage our oncologists to do is, once they've been identified, obviously, as having breast cancer and completing their therapy, because we know at that point they're only focused on their breast cancer therapy, but when their last session is, that they should get some risk screening for cardiovascular disease or be referred to somebody who does that, because that is the perfect time. They are now more likely to survive their breast cancer because our therapies are so good. They are at a heightened risk of developing cardiovascular disease. And we think that all of them should go through the same sort of risk assessment and be able to help them prevent cardiovascular disease. Same with lupus and rheumatoid arthritis, psoriasis. There's some emerging data about inflammatory bowel disease, but it's kind of mixed, so I'll just avoid that for right now. But these, especially lupus and rheumatoid arthritis, where we have the strongest data, those are diseases of inflammation, right? And they are much more likely in women than men. And we know women already have a baseline more inflammation than men. C-reactive proteins are, for example, higher just in general in women than they are in men. We are inflammatory people, I guess. Women are, but by inflammation. And then we have this, but that is, when you have excess inflammation, there is something about those diseases. And it may be the disease process, it may be the inflammation, it may also be the medications that we use to treat those diseases. So there's a lot we still need to know, but now at the Mayo Clinic is one example where they actually have a cardiorheumatology clinic, and they identify those women, they make sure they get all the screening for cardiovascular disease as much as they're getting the treatment for their underlying conditions. We just need those women to know they're at a greater risk, or their physicians, and then at least get them to the right people.